this presentation. I used to do it and to present it into conventional conferences, so I had to convince the audience that there's more disgusting things than probiotics to apply on wound care. You see here maggots and these bloodsuckers. Just to explain how I came upon this topic. The year 2023 was very yielding for me. I took a few trainings, one in wound care as a general surgeon in the UAE, and no one wants to take care of wounds. It's a burden for everyone. Plastics wants to do plastic, and ortho wants to do ortho. It's only down to the general surgeon to do to take care of everything. So I took that IWCC course the same year. Which I did not mention here is I took functional medicine, which is a holistic approach to the patient, which got me to familiarize myself with probiotics a bit more. And then I went to South Africa to be trained in trauma surgery, where I met Dr. Kleinches that spoke earlier. All of these trainings kind of opened my mind to a different way to help the patient. So just a quick reminder about the wound healing process. You guys don't necessarily know about this, but there's just to know one thing. There's 4 overlapping phases into healing, which start with hemostasis, we stop the bleeding. Then there's a phase of inflammation. There's a lot of white cell, immune cell system that's being lit up and brings cytokines and a lot of molecules to help promote the building tissue. Proliferation, which is a skin cell phase of multiplication and migration and remodeling, because all these cells will end up synthesizing a lot of collagen that needs then remodeling. During my stay in South Africa, Dr. Kleinches taught me a lot of things about burn management, and I got to know that most of the mortality causes are related to infection. And that got me to be exposed to the history of these infections. So when a patient comes being burned, at first, the burns are thought to be sterile for a good 1 to 2 days. And I'm saying thought to be because now we're discovering that there's always a minimum amount of bacteria. The following 2 days, then after the following 2 days, we have the skin bacteria from the hair glands, from the sweat glands that come and colonize the burns, not necessarily causing infections. Later on, as the burn patient, depending on the severity of the burn, you have what we call translocation. You know, there's microbiome, the concept of microbiome, it's everywhere in the body, in the mouth, in the lungs, in the gut. So these bacteria kind of traverse the walls of these organs, get into the bloodstream, and can go everywhere, including the burns. So you have on these burns germs that we would find in the colon normally, gram-negative bacteria and whatnot. The last ones would be the yeast and fungi. So when you deal with wounds, you have to know the concept of biofilm. So most of the acute wounds will later on develop what we call a biofilm, which is like a coat that protects the wound bed and also the bad bacteria. All wounds are colonized by definition, and depending on the type of colonization that you find in a wound, you may have this wound turning into a chronic wound or not. And the bacteria that you will find in these wounds with biofilm tend to be more resistant to antibiotics and antiseptic. It tend to be very virulent. So it's bad news for us surgeons because the knife can't do anything about this. The more you cut, the wider the wound gets, and it doesn't solve the problem, it just makes it worse. And it's difficult for us surgeons to accept this. Like I said, the biofilm is like a matrix that protects the bacteria that maintain the level of inflammation of the wound. Most of the bacteria that you find in them would be the gram-negative, the anaerobis, and I didn't put it, no, I did, aeruginosa, which you find a lot in the ICU settings. And like I said before, the major route of contamination of those patients are us, the healthcare givers. No matter what we do, PPE wearing, washing our hands, etc., it'll always be us contaminating them with these bacteria. So this paper is actually, so the study that Dr. Kleinches mentioned earlier is the one that triggered our talk, because as soon as I got to discover the topic of using probiotics in such a vulnerable unit in a hospital, because ICU is like the most, I would say, the most deadly unit in a hospital, I was shocked and amazed. And to know that he was able to reduce the number of hospital-acquired infections from half just using probiotics to clean the environment of the patient, it got me thinking, if we could use it on a neutral surface, could we use it on a patient to obtain more, like better results in terms of wound care? So going back to the same definition of the WHO, I'm not going to extend on this. You guys know now how we define a probiotic, just the concept of bacteriotherapy using probiotics for either topically or systemically, meaning swallowing it. Most of the probiotics that we study, you know that now, lactic acid making bacteria, big family of the lactobacilli, bifidobacterium, Saccharomyces boulardii being a yeast. A quick note on the topical bacteriotherapy. It's not such a new concept. I was kind of disappointed to see that it was already known back in the 20th century, known for a lot of actions, which I'm going to detail later on down the line. A quick word on the literature. What does the literature have to say about this? So you've got this huge systematic review of what this scientific world has to say about the safety of probiotics. Basically, it's safe, as you all know. And I should just mention this, the second remark you see on this slide, I totally agree. I mean, a whole history of thousands of years of use of probiotics, whether it's in the form of capsule or in form of fermented food, should be proof enough of safety as far as I'm concerned. Another big safety study was done in Scandinavia. Finland and Sweden had followed for 10 years their population in the time that probiotics were being in trend and being used quite a lot. And they saw no issues in terms of bacteremia, which is multiplication or presence of bacteria into the blood. So no real danger in terms of systemic symptoms. You can see here there's also no notion of resistance to antibiotics as far as probiotics are concerned too. This systematic review is also quite relevant, relatively recent, 19 studies, a lot of RCTs, randomized controlled trials, most of them done in general surgery, very vulnerable population, Whipple procedure. I don't know if you guys are familiar with this. It's pancreas surgery, one of the most delicate that we have, that and liver transplant. So these patients were followed after use for the use of probiotics, and a significant decrease in complications like wound infection was noted. In the burn population, it's also studied quite a few times. Peral, which I'm going to detail later on down the line. Peral only on a topical level. That's why I'm going to go back to it. But again, systemic use of probiotics leading up to a decreased rate of morbidity and maybe sometimes mortality. This this one I wanted just to mention because it's a recent study, recent systematic review. They mention an Iranian group that have studied the oral use of probiotics in gynae patients post-delivery for the sake of the episiotomy. And they noticed such a tremendous improvement of the healing rates of these episiotomy wounds that they're now considering doing a study on the topical use of probiotics. That's how motivated they were by their results. Another systemic review showing a lot of trials. So it's been tested in animals, obviously. It always starts with animals. Just here to show you some pictures of, this is the line of the use of probiotics on rats that we wounded. And you could see that the healing process is quite smooth. There's no raised inflammation. It's quite discreet, and you can hardly notice a scar formation at the end. Dermatology now, they can defend the use of probiotics for a lot of conditions, dermatitis, psoriasis, etc. It's all in the market. It's been proven. There's a lot of studies to back it up. And just this to explain the principles behind this, you've got obviously two sides to the effect of probiotics. You've got the fighting of the bad germs, and you've got the promotion of a healthy healing. Fighting off the bad bacteria, how does it happen? You have the fight for the nutrients. It's like there's a competition for food in the wound bed. There's then the lowering of the pH because, as we say, lactobacillus tend to make lactic acid, which acidifies the milieu, which the alkaline loving bad bacteria cannot tolerate much. And there's also the release of bactericide agents that will directly attack the bad bacteria present in the wound bed. All of this will lead to the disruption of the biofilm, which is what we need to get rid of these chronic wounds. This is just to repeat the principle of the probiotic action. Here we have these studies that actually explain why the dermatologists now prescribe topical probiotics in wound healing, in skin inflammation conditions. And there was also this interesting fact that there's more oxytocin release when you use Lactobacillus reuteri. Now I'm going to try to draw your attention on these two studies coming from the same team back in 2009 and 2010, Argentina. This is a burns department. Burns department studying the use for the first time in literature that I can find. They compared the use of the standard treatment for burns, which is a cream with silver. Silver is a very common antiseptic agent that we use in burns. It's the first line product that we use, no matter what setting you have. It's still being used today as a first line. They compared this cream to the use of topical Lactobacillus plantarum on the wounds, and they noted a complete wound healing in that was more frequent in the group treated with probiotics. I'm not going to bother you with the skin graft rate, which was also very excellent, but safety, because no side effects attached to the use of topical probiotics, and even better results as opposed to the gold standard treatment. So this was very encouraging. And now the second study, which is more relevant to my group of patients, and you will see why. The same principle, topical use of lactobacillus on venous ulcers in patients. They compared the group that had diabetes and a group that didn't have diabetes. Why? They wanted to show that regardless of the terrain of the patient, regardless of their immune system, whether it's good or bad, you still have the same result of healing. And this was shown in their study. There was no significant difference between the two groups in terms of healing. And this is key. Just a quick mention of the limitations. The problem with probiotics is that the microbiome is very specific to the individual. My microbiome is not the same as yours or yours. So you can never have a study that's going to be scientifically rigorous enough to make a point in terms of the gold standards of publishing. Nonetheless, we still, like I said, we have thousands of years of experience of use of probiotics, and this is enough to back up this idea that they can be used safely for our benefit. Now I'm going to get into the cases that I have taken, so it's going to be a bit more fun. You're going to have some before and after pictures. Just a quick note, in the UAE, you might not be familiar with this, but they don't necessarily let their people die. Whatever the age they have, the elderly will stay in sort of ICU units. So they'll stay intubated or through the mouth or track for months on end, sometimes years. You'll have these patients from 60 to 90 staying in bed, having dialysis, heart support, liver support, kidney support, and respiratory support. And these are the worst patients I've been exposed to. They have absolutely no health to work with. I just want you to understand this. These patients stay 2 years, sometimes more, lying down, being turned every 2-3 hours when they can, when the nurses can, developing sores that stay and will be ultimately the cause of their death, that stay on 1 year, 2 years with no hope of healing. Because when you don't have a heart condition, when you don't have a heart working, a liver working, kidney working, it's very hard to hope for a healing. So now, this context being described, I'm going to go into the first patient who was a compassionate case. So that's how we got to start and motivate the team to get on board with the study. This chap, 87, I ended up amputating above knee for a history of peripheral arterial disease. He had a necrosis of the foot that didn't go well with the conservative management. He was already on dialysis. He was already in a coma with the track, demented, etc. The amputation went well. Actually, he healed and had a dry wound within a good couple of weeks, which you see here. Not the best stump I've had, but you know, it's right out there. And at 1 month post-op, he started to develop some sort of dehiscence, the breakdown of the wound. Very local and minimal, as you can see, but it did not evolve in the right direction, regardless of all the consumables that I'm used to in wound care. I even tried negative therapy, and it only went worse. Sorry. So within a month post-op, more than a month post-op, he was still not septic. He was not feverish or anything, but you could tell on the labs that he was not going in the right direction, and the wound was worsening, regardless of what we did. And the germs that we found was the Pseudomonas, and I don't know if you can see here, but resistant to everything. It was a very bad bug, the kind of bug that you find in ICU only, resistant to all the antibiotics that we have available in the pharmacy. Obviously, the patient became septic, having no good health whatsoever to support himself. Pseudomonas was found in every possible testing, sputum, urine, skin, and he was not responding to antibiotics, obviously, because no antibiotics that we had in our possession could fight that one. So we discussed with the family and convinced them that he was not a surgical case, but we could still try that last resort of topical probiotics. So this is the first day that we applied it. Dry wound, absolutely no blood coming up, no fresh flesh, as we could say. The next 3-4 days, we have some budding of fresh granulation here and there. So we got encouraged, we continued, and within a week, we have this a bit more granulation. Antibiogram came from this one, which is the original one, to a full shift within 12 days, and you'll find it interesting. Candida, sensitive to everything, but no Pseudomonas, no Klebsiella, nothing. And nothing about the probiotics that we use. No lactobacillus there. Within 2 weeks, you can see a net change. I should specify, I cleansed the wound only with hydrogen peroxide, nothing else, no betadine, no whatsoever. Within day 27, it was a full recovery of the wound bed. I was about to close him up, but he died of mesenteric ischemia. So I could not finish up this one. It was very frustrating, but it gave me motivation to expand to other patients. So this one, another nightmare, I'm sorry to say, 60s, deeply depressed. So he was not eating. He had a PEG tube for feeding. He was severely vascular and had this arterial necrosis ulcer. We let it, usually what we do, we don't touch it surgically. We let it kind of demarcate itself, and then once it's easy to peel off, we then cut it out. So within 2 months, we were able to debride this. Initially, the antibiogram of the pus swab didn't show much. It was an E. coli that was, no, Enterobacteria, that was quite friendly for an ICU patient. But he stalled the healing. For 8 months, we didn't progress that much. Again, regardless of the arsenal in our disposal, we could not help out this patient. And the antibiogram shifted to an E. coli that was really nasty. So we started the probiotic protocol with him. And within a week, a bit more granulation. Within a month, we had like a shrinking of the wound bed. Within a month and a half, a flattening of the wound bed. It was no longer a cavity. Same in 3 months. And after a total of 13 weeks, we obtained a full healing. So I understand this is the whole healing. So I understand that 13 weeks doesn't strike you as a fast healing, but you have to keep in mind these patients kept this wound for more than a year, like for roughly a year, before we could finally take care of the wound with the probiotics without using antibiotics. I have to specify this too, and without using antiseptic that would actually spoil the surrounding skin as well. Another case, and this one was a challenge. Why? Because it was a perianal ulcer that was very deep. You can see the cavity here. It went straight to the coccyx, very wide. The patient was having diarrhea. So this was caused by a wrong enema procedure by the nurse. Bedside, sometimes it's tricky. And it went on and worsened because of the diarrhea, constant diarrhea every day. And this area is not dressable. So you can't keep a dressing that sticks to the skin technically. It's a challenge. So it kind of stalled for a few months like this. We did not, we applied the probiotics, but we were never able to apply a dressing. So what we did is that probiotic, we had a mix, gauze to protect it, a bit of tape. Whenever he would have diarrhea, wash it off and repeat. So a bit strenuous, but we do what we have to do. And so this is 10 months of evolution and stalling, no healing. And within 2 months, 2.2 months, we have a total healing. In the anus, like in the perianal area. It's just, you never have that. You never have that in an ICU patient. Never. With diarrhea. This is the more recent patient that I've had. Chair confined, 73-year-old male, obese, not the best health, but still he was living at home, so he was fine. He had multiple pressure ulcer, but I'm showing you only 2 things. One anal ulceration and one left hip chair sore. He was still pressing on it. The way you manage the sores is that you relieve the pressure. You tell them never to sit on it or to lie on it to promote the blood supply and let the wound recover. So we're gonna see the anal one. I don't know if the image is clear, but it started as a roughly 2 centimeter wide into the anus. You can see here, this is the anus with the diarrhea. He was diarrheic as well, with 2 or 3 episodes every day. Within 10 days, you can see the shrinking of the wound. And 2 weeks, it was healed. In the anus, with constant diarrhea, and in his case, the probiotic could not be renewed because he was staying at home. So the caregiver was not able to always make the mix that we were making. So this is even more impressive in terms of my consideration. And the left hip, I'm showing you. This guy stayed 2 years coming every day to the clinic of the surgeon before me, having betadine-soaked gauze packing. That's all. So antiseptic, the same every day. And no healing, obviously, but only went wider. Less than 2 months with this probiotic protocol, and we were able to actually reduce it to 1 centimeter. Sadly, I had to leave the clinic before I could manage to heal this one. But just to give you the expectation now that I have with probiotic use topically on these patients. This one is a very interesting case. It's a burn patient, diabetic, didn't feel the warm water disposal system that he was using to relax his muscles. Didn't feel the burn, came to a surgical clinic, not mine, and started some debridement with the surgeon, constant debridement because they were not getting the blood. So basically what you learn as a surgeon is that you have a wound, a burn or another type of wound. If it's not bleeding, it's not going to heal. So you cut it out, so you promote the blood coming to the wound bed. But the surgeon kept on cutting and no blood was there, only fibrin, whatnot. Patient stressed, came to me. We used topical probiotics, and for the first time, we started having granulation. as a ring, because the trickiness of this case is that it's right on the malleola. So under the skin, you only have the bone. So there's no rich blood supply underneath, and he's diabetic, mind you. So blood supply is already a challenge as it is for these patients. And we managed to have a flattening of the wound until the full healing, for which he was very grateful. This one last case, very interesting case, old 73-year-old lady, diabetic, completely poorly managed, cancer. She was not aware of cancer stage 4, so breast cancer with mets in the spine. Obese, goes through to get an MRI because of her spine issues. Gets burned into the MRI, and you can see here there's a blister, so at least a 2nd-degree burn. She's wrongly referred to the dermatologist, which is not the reference. It's not the reference burn specialist, but anyway, it was a mistake from the emergency department. Stayed with the derma for a month, who only applied fusidine topically. Fusidine, for those of you who do not know what it is, it's just a topical antibiotic. She did not end well. Look at the dark tissue here. That's completely full thickness necrosis of the skin. It was mid-debridement. I had to take it away. I had to debride it. Within 2 days of classic burn management without probiotics, you can notice here, it's dry. There's no serum coming out, there's no exudate, and there's no sign of the edges you see, they're not healthy. So I start my probiotic protocol. These are all the pictures throughout the process. Within 14 weeks, she stopped coming to the hospital for materialistic reasons. But so she did the protocol herself with her daughter. But today she's healed, and I have to attract your attention on one topic. All of these patients, I don't know if you realize this, but the healing that they have is quite smooth. It's not keloid. It's not hypertrophic. It's never protruding. It's always homogeneous. It's very balanced. You have in some patients, and I'm sure you know at least one person that heals in a very pathologic way that makes brown scar or bubbly scars. None of these patients did. None of these patients did. A worry that you have when you do wound care in patients that takes a long time is that they may develop also some cancer of the skin, because you've got some area that works for a long time that can promote some DNA disturbances. These patients never shown any, have never shown any tendency to develop any anomaly of their scars. None of them. This is going in the same sense that parallels to the study. No matter, regardless of the patient, regardless of the immune system that they have, there might be a mummy, for that matter. I'm consistently thinking that they will heal. So there's a need, obviously, for a multi-center study, which with Dr. Kleinches we're working on. We've applied already for a grant, and it's a matter of time before we start in the UAE. But this is for your notes in case you want to collaborate on the topic, because we're very, very interested in probiotics. Thank you very much.